So yeah, hi, my name's Clay, and I chose the myth or kind of rule that's been going on for a long time, but all bacteremias requiring 14 days of antibiotics. Just to kind of start off, I wanted to define complicated versus uncomplicated bacteremia. I don't need to go over every single thing there, but essentially, uncomplicated bacteremia uh, is where there's an identified source, you have source control, and you have rapid clinical improvement. Versus complicated bacteremia, meaning there's some sort of deep-seated infection, uh, some sort of maybe hardware or other catheters or whatnot that can't be removed, and also immunocompromised hosts. I'm kind of going to go into more detail about why I wanted to define this a little bit, but starting off, where did the myth come from? So way back when, transitioning from using sulfonamides to the penicillin era for treating infections, there was no real structured duration trials or any sort of RCTs that looked at what the appropriate duration of antibiotics were. A lot of it was described in just case reports and clinical observations by doctors and other experts in the field. Um, Many different reviews that summarize the transition from sulfonamide to penicillin show treatment durations were just anecdotal or case series based, so just from prior experience. Uh, yeah, and there was no formal randomized control trials that were kind of dictating this treatment duration. So pre-antibiotic era to the early antibiotic era, so the 40s to 60s. Pre-antibiotic era, there wasn't really much other than, source control. If they had osteomyelitis, amputation, so on and so forth. Um, but again, just reiterating the point that treatment durations were not studied in a randomized control trial fashion. It was more anecdotal. Uh, the first recommendations that they started publishing were in textbooks and review articles. And this was usually suggesting, 10 to 14 days as a safe period. Uh, that was, you know, not trial based, but probably largely due to relapse fears. Also, early pharmacology with antibiotics having shorter half-lives and less tissue penetration. Um, More on the topic, so catheter-related bloodstream infections, some guidelines that were published in the 80s and 90s were suggesting 10 to 14 days of antibiotics if the catheter was removed or longer if not. And I put this in here because these recommendations were quoted and widely generalized to just include all bacteremias. So not using the recommendations for their intended purposes, but kind of just generalizing it in. Um, and then also some of those infections that we really worry about. So staph bacteremias, they are associated with higher morbidity and mortality, along with more complications. So data back from the 1970s and 1990s, they had higher relapse rates when therapy was less than 14 days for any sort of staph aureus bacteremia. And this was, again, just kind of extended to include all bacteremias. So kind of entrenching that 14-day minimum for any sort of treatment of bacteremia. And then how did it kind of enter medical teaching? So in the 80s and 90s was when infectious disease textbooks started carrying these sort of blanket statements saying that bacteremia you should treat to 10 to 14 days, largely driven by, anecdotal case series data, fear of relapse. And it was just kind of a general teaching convention and not very pathogen specific. So they were taking data from, the Staphylococcus aureus bacteremias and kind of just generalizing it, or the catheter associated bacteremias, and just associating it with all bacteremia. And that was just kind of, passed down between all uh, forms of medical teaching. So, at grand rounds lectures or in textbooks, it just kind of came this general rule of thumb that if you are bacteremic, you get 14 days of antibiotics. And then things didn't really start to get questioned until the 2010s, when they started doing more research into, where did this come from and are the guidelines appropriate for what we're using these antibiotics? Kind of just going back to that skit earlier, antibiotic stewardship. Do we really need to expose people for long periods of time with antibiotics? We don't really need to. This is one systematic review trial that I found, um, looking at the duration of antibiotic therapy in bacteremias. This was a meta-analysis from the Critical Care Medicine Journal. They looked at trials from 1947 all the way to 2010. They included studies with all types of bloodstream infections, with all types of bacterial causes and all kinds of sources. There was very, very few RCTs that they looked at. Most were observational studies, and comparing different durations of antibiotic therapy was their goal. And they were looking, at the mortality, relapse, recurrence, treatment failure, and adverse effects. So what they concluded from that paper is that, the recommended 10 to 14 days for all bacteremias is not based on trial evidence. It's more a case-based series. And that they also found shorter durations, roughly 7 days, appeared to be as effective as longer durations. And they kind of came to the conclusion that obviously we needed more dedicated, large randomized control trials just to, kind of get a better gauge and guideline on duration of treatment for bacteremias. And that kind of leads us to the other RCTs that I'll talk about later. And this is just kind of a summary slide of what I just went through. But again, they searched from the 1940s to the 2000s. There was 24 studies, mostly were observational, very few RCTs, found no trial evidence supporting the 14 days as a universal duration, and just highlighting the need for more formal randomized control trials. So in preparation for a lot of these things, they did surveys. This one was a Canadian survey. They asked ID specialists and critical care specialists just to see what their, professional recommendations or their professional practice was in treating bacteremias. The Canadian trial found the recommended, or the median duration that people recommended, were 14 days. Shorter durations were typically reserved for uncomplicated gram-negative bacteremias, and longer durations for Staph aureus or complicated bacteremias. And when asked why they recommended certain durations, it was, again, due to relapse fears, severity of the infection, and just ingrained teaching that they've had. Another survey that they did, this one was in New Zealand and Australia, again, surveying infectious disease specialists and critical care specialists, showing, there is a big substantial variation in the recommended therapy durations. Some 7, many 14, and others greater than 21 days, depending on what infection they were treating. Most agreed on a 14 or more rule for treating Staphylococcus aureus bacteremias. And then for gram-negative bloodstream infections, they had the highest variability, reflecting just uncertainty of what the recommended treatment duration would be. And these kind of were in preparation for the following balanced trial that was recently published, which I'll talk about in a bit. So challenging the dogma, do we need 14 days of antibiotics for all bacteremias? This first trial by Yahav, this was a multi-center open label non-inferiority randomized control trial conducted in Israel and Italy. Um, they had 604 adults with uncomplicated gram-negative bacteremia. So they had a pretty tight inclusion criteria. They also excluded anybody who was unstable, didn't have source control, but they did randomize 7 versus 14 days of antibiotics. And their primary outcome they were looking at was overall mortality, relapse, complications, and readmission rates with length of stay as well. Um, this graph is kind of just uh, showing their results. Um, they had they split it up between UTI source and non-UTI source, and then as you can see, the 7 days showed non-inferiority to a total of 14 days for treatment of bacteremia, regardless of a urinary source versus non-urinary source. Again, it's important to note that this was uncomplicated gram-negative bacteremia for a stable patient. So it has very limited uses or clinical applications besides those tight criteria. This is just looking at their primary outcome, showing no significant difference or a non-inferiority of treatment of 7 days versus 14 days. And this just kind of goes to challenge that rule that all bacteremias would need 14 days of antibiotic coverage. And then a more recent trial, the Balance trial, which was published, I think, in May of this year. This was the largest randomized control trial yet that they did for looking at treatment duration for bacteremia. It's an international trial, multi-center, again, looking at non-inferiority, had 74 hospitals in 7 different countries. So it's a pretty substantial population of patients. Looked at around 3,500 hospitalized patients with bloodstream infections. They didn't exclude stable versus unstable, so they included ICU patients as well as just wards patients. They did have pretty stringent exclusion criteria. They didn't look at anybody who had a Staph aureus bacteremia or other indications that would prolong the course of antibiotics, which this just kind of gives a little bit more detail into. But the main exclusion criteria was if the patient was severely immunosuppressed, if they had infections that already required prolonged duration of antibiotics, so any sort of deep-seated infection like osteo or endocarditis. And then, of course, questionable cultures or Staphylococcus aureus bacteremias. Another one they excluded was the Staph dungeness, which is a skin commensal organism. It's one of the coag-negative staph, but it is implicated in causing severe deep-seated infections. And then patients were randomized 7 days versus 14 days. They did let the treating physicians dictate what antibiotic they were using and the route that they wanted delivered. And they just didn't tell the treating physician whether or not they were going to be getting 7 days versus 14 days until that 7 day mark, just to try to mitigate some bias. Primary outcome that they looked at was 90-day mortality. For the 7 day group, had a 14.5% mortality, and the 14-day group had a 16.1% overall mortality, with a difference of 1.6 confidence interval, -4 to 0.8. This is just going to show that the 7 days of antibiotics was non-inferior in treating uncomplicated non-Staphylococcus aureus bacteremias in either stable or unstable patients. They also had a lot of broke it down in many different ways as well. Um, but this trial was great because it wasn't just looking at gram negatives, but it included both. If you can look at the bottom there, you can see gram positives, gram negatives, and polymicrobials. Um, and then it also just broke it down based off of infection type. Um, yeah. Um, Secondary outcomes that they looked at was relapse, length of stay, number of ICU days, which they didn't see any significant difference on. And then also concurrent C. diff infections were similar both between the 7-day and 14-day groups. And overall antimicrobial resistance, they didn't notice a significant difference. So really, this is just going to show that in terms of overall mortality, 7 days of antibiotics is equivocal to 14 days in uncomplicated non-staph bacteremias. So what do these few trials say about 14 days for all? Um, it really emphasizes just patient selection. So it's not a 14 days for all approach, but rather who can I treat with less than 14 days? The first paper I talked about goes to show that uncomplicated gram-negative bacteremias, 7 days is equivocal to 14 days. And then in the balance trial, included a lot more pathogens, implicating pathogens. But for any uncomplicated bacteremia that's not Staphylococcus aureus, 7 days is equivocal to 14 days for mortality alone. Um, so evidence kind of points away from the universal truth that all bacteremias require 14 days of antibiotics, and it's more emphasizing a patient selection approach as opposed to a generalized 14 days for all approach. Um, and this just kind of reiterates some things that I was talking about, but the message is not a blanket statement of all bacteremias requiring 14 days, but rather using better clinical judgment to see if your patient falls into any of the categories that would allow you to use a shorter duration of antibiotics. Yeah.
All right. Any questions or comments from anyone?
From the last set of negative blood cultures, or
It was So it was 7 or 14 days from initiating of appropriate antibiotic coverage on the blood cultures.
The trial that you just I sorry I missed it, but did they like I'm assuming they did, but did they separate the ICU and wards patient in the result that you showed the difference? Or did they have them to like I think it's the previous slide maybe? Or they did it okay. I'm just curious about the difference, I guess, of like how significant the difference was with ICU patients versus wards patient between the 7-day and the 14-day course.
Um, I don't remember off the top of my head if what the actual difference was, but the overall conclusion was that the 7 days was non-inferior to the 14 days.
Okay. I think this is kind of one of the classic type myths, right? I mean, how it started, he went through pretty extensively the history of how this practice became ingrained into our practice over the years without really any good evidence other than just anecdotal data, basically, for a long time. So I don't know. I don't know what Dr. Jose's practices are at this point, or whether this makes any difference to anything you've been doing, or. Oh, I take it. Yeah. Right. Yeah. Okay. So thank you. I think, hang on. Let me get back to, am I going the wrong way? So is it a myth? It's time to vote. For those of you who haven't, I guess there's some new people here that haven't been to one of these before. So we always vote afterwards as to whether this is the topic is a myth or not. And you can either vote that it's confirmed, yes, it's a myth, or it's busted, or it's plausible. They're still not, you're still not convinced, but it looks like it may be true or may not be true. So what we're voting on is uncomplicated bacteremia should be treated with antibiotics for at least 14 days. So how many people think this is true? How many think it's plausible? How many think this is busted? Wow, it's unanimous. That's pretty good. All right, so okay, so I click that. Hopefully it'll work. Thank you.